Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar Kulkarni, and I work at one of the world's best children's hospitals, where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation. And over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before we get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started. In today's episode, we're diving into how technology is transforming pediatric care, from the clinic to the home and even into virtual worlds. I had the privilege of speaking with two visionary leaders, Dr. Zafar Chaudry, who shared how AI tools are helping clinicians make better decisions, why the digital front door matters, and something as unexpected as Minecraft and how it can improve patient experiences. And then I spoke to Dr. Bimal Desai, who walked us through the power of remote patient management and virtual care in creating more connected, compassionate healthcare. Together, their insights paint a picture of what's possible when innovation meets empathy. First, I speak to Dr. Zafar Chaudry, the Senior Vice President, Chief Digital, Chief AI, and Chief Information Officer at Seattle Children's Hospital, where he leads transformative technology initiatives to empower clinicians and improve care. He began his career as a physician and has over 3 decades of international experience in healthcare informatics, enterprise infrastructure, and digital transformation, with leadership roles in the United States, UK, Europe, and Australia. Dr. Chaudry is a globally recognized innovator, repeatedly honored on prestigious lists such as Becker's Hospital Reviews Hospital CIOs to Know, and he has driven major advancements in AI, business intelligence, and electronic medical record systems. I appreciate you taking the time to talk to me.
My pleasure. Thanks for having me.
I saw that you've said that AI can be easy to launch but hard to sustain, and you've stressed the importance of people and process along with the technology. So, as you're doing the work at Seattle Children's, are there cultural shifts and process shifts that you're making in addition to all the technology deployment you're doing as it relates to AI and other digital deployments?
Absolutely. There's a lot of fear around AI tools. So you've got nurses wondering whether these tools are going to impact their working life, their jobs, people thinking maybe it'll take my job away. So you do have to manage the cultural aspects, the change management process, the buy-in. It's still a sales job. I always tell people IT is sales. We have to go in and we have to show people that these new tools are beneficial. There are some jobs that will go away, but we can retrain people to do other jobs. And that's the message that doesn't always filter through, because when you hear the version from tech companies, they're very much touting savings, reductions, people, etc. But in clinical settings, it's slightly different, right? You've got some back office function you can automate. You've got front clinical work that, hey, you can help your physicians go home earlier, get less pajama time, use some of these AI tools, even nurses, if we can help them with their documentation so they can spend more time doing what they love, which is spending time with the patient. These are all things we as IT folks have to work through. It's not just a matter of, I went to a conference, I saw the next shiny agent and I bought it and I implemented it. I think you've got to work through all those people, cultural process issues.
For the first time in a while, we in healthcare are going through the same technological transformation as other industries. Often it feels like we're behind thinking about telehealth or digital front doors and other things that we've done in the past. We haven't necessarily done them at the exact same time as banking and manufacturing, et cetera. But with AI, it seems like we're in it at the same time as everybody else, which is creating an interesting cultural dialogue where what we're doing in healthcare is being covered from the same media outlets that are covering what's happening in other sectors, which is creating an interesting both opportunity, but also challenge as we think about change management, the fear, the trust, and the deployment of this technology.
Yeah, I think you're correct. But I think where we slightly differ in this space is that there are less off the shelf, out of the box solutions available to us than other industry. Because we're not manufacturing a car. We're actually dealing with people, and every person, even though anatomically and physiologically are the same, there are some quirks and differences. And then you have personality issues, which don't tend to factor in on a manufacturing line per se. So, yes, you're right. I think we're hitting the same pace with other industries, which is a first for us. But at the same time, we're learning that we are somewhat bespoke with some things. Some things have to be built for the use cases. And what we're seeing demonstrated to us from tech companies is off the shelf stuff that they built in other industries that may not necessarily be immediately pluggable into our business. Besides the basic, I can help you write an email or create a Word document or PowerPoint. That is pretty much standard, but other things are not.
One of the problems that exists for clinicians is the retrieval of information because there's so many trials, so many studies, so much research happening. Medicine is evidence based, and clinicians need to continuously absorb and synthesize that information so that they can be at the top of their license and providing the best care. I've read that you partnered with Google recently to build an AI powered tool that can do that. From what I understand, you can pull together information from various sources and create a synthesis for your clinicians. Tell us more about that project and what it does.
Yeah, so what we're describing as Pathway Assistant is an amalgamation of all of our clinical pathways that have been built over many years. So every pediatric hospital builds out pathways, and that's how we take care of our patients through all the multiple specialties. For us, that's thousands of pages worth of PDF validated by our clinicians all the time. But trying to find information in there is like pulling your teeth out, right? So by building an agentic AI that can have a conversation with you about this data and or this data only, it's not pulling from any non-verified source. This was one of the things our clinicians asked us to build, and it was built by clinicians. We did the coding in the background, but we had about 50 physicians work on this project from informatics and other specialties. And they volunteered a lot of time to test it, make sure it was correct, accurate, no hallucinations, no biases, all of those things that you should be doing when building these tools. And that's what we've built, and we've just launched that. And that's built on Google Gemini, and it pulls data from GCP platform.
So, give us an example, a use case of how this would be used. What's the type of prompt that a clinician may ask, and at what point of the workflow may they ask it?
So the little bot opens up, you open up Pathway Assistant, little bot shows up and says, "How can I help you today?" And you can say, "I'm in the emergency room. I've got a 5-year-old child who's having difficulty breathing, is sweating, has a fever, cough, all of those things. What should I be doing?" And then what it will do is it will troll through and say, "Okay, why don't you go and check these other things or run these tests and these x-rays and come back and tell me what you found." And so when you come back and you input, "This is what we found, this is the blood pressure, this is the respiration rate, this is the temperature, we did some x-rays, this is what we found, ran some lab tests, this is what we found," it then trawls through the data that it has access to and says, "Okay, now I want you to go and do an MRI or CT, and then come and tell me what the results are for that." And then as it's trawling through this conversation piece, it eventually ends up by giving you a differential diagnosis, right? Hey, these are the 3 things your patient probably has, but now you need to go and confirm that. To confirm that, these are the next 3 things you need to do, and then come and tell me what the results are. And then it helps the doctor narrow down to a final diagnosis. And of course, the doctor still has final say, but it now becomes, I like to say, it's like your phone a friend, right? So it's going back and forth and it's giving you this guidance. Really good if you're a doctor in training, because you don't know these things till you look them up in a textbook, but now you can have this conversation and it's guiding you through, which means you'll remember what to do next time you see a patient with the similar symptoms and outcomes. And that was the goal. And then if it comes up with, "Yes, this is what we think the diagnosis is," it'll then say, based on our protocols, this is the medication you should give. This medication, this dose, then it'll say, what is the weight of the patient? And you put the weight of the patient in, and it'll say, well, actually, based on this patient weight, male, female, etc., this is what you should give. Now go away and give that. So you still can say, well, I don't agree, but it's built from medical care that we have established over the last 30, 40 years. So to me, that's super cool because it's helping you get to a differential. It's helping you like the Sherlock Holmes things, right? Because that's what medicine is to a greater extent. You're asking questions and you're looking at symptoms and you're looking at results. And in the past, physicians would do that in their head. They'd come up with a differential, they'd write it down on a piece of paper, then do more tests, narrow it down to what they really think it is, and then treat it. So we just built that out in this agentic AI. And the clinicians helped us build that. So we're excited about that because I think it's hugely beneficial for the residents and it's hugely beneficial for physicians who just want to double check what their thinking is. Because they used to do that before. They used to press Control and F and scroll through all those and then read them and then validate in their head, yeah, this is what I was thinking. Now you don't have to do that. That's why I think we're excited about it.
It's a tool that you could think about as an educational tool, a training tool. Does it pull from your Epic EHR?
It's pulling only from our pathways.
This lives outside of the patient's
Yes.
electronic health record experience.
Yes. When I was practicing medicine, we used to call that the Oxford Handbook that we used to carry in our pockets. And it was a short version of the bigger textbook of medicine. And you would scroll through the pages because they had a page for each condition. And that's how you would work out whether you were doing the right thing. It's just an evolution of that. But now you can have that interactive conversation. You can talk to it because it's voice enabled, or you can type it in. Right. So depending on if I'm carrying my iPhone and I'm trying to figure this out in a very high pressured setting, it's supposed to help you. But we haven't sold it to anyone in the sense that you still have to put your clinical experience into this, right? Because we're not trying to override your clinical judgment. We're trying to help you get to the answer as fast as you can, because that's a patient safety thing.
Of course. I could see this being very helpful for nurses. There's a lot of new nurses coming out of nursing school or even nurses who've been practicing for years and years. I could see a different version of this tool being helpful.
Yeah, it's pretty much the framework's there. If we take out our physician pathways and put in nursing pathways, it's going to act the same way. We'll still need some nurses to test it by asking it lots of questions. We could take out our pathways and you could put your pathways into it. But imagine a world where we take all the pediatric pathways from every system in the world and put it in. What would it do then? That knowledge would be mind-blowing, right? In terms of how you do it, how we do it, how they do it in London, how they do it in Dubai, how they do it in Sydney.
Now, you've done work to reduce the use of opioids. You've used AI to work around neurologic patients and stroke prevention, perhaps. Tell us more about those projects.
Our partnership in data and analytics has been with Google. And we used to be an IBM and a teaser on-prem, and we moved everything to Google Cloud over the last 18 months. And so it's really about we're sitting on a bucket load of clean data. It's about 171 systems fed into our data lake. And what we're looking for is trends, right? So what people don't know on a day-to-day basis practicing medicine is, hey, we give a lot of opioids to put kids to sleep. And then when they go home, we prescribe opioids for their pain. But nobody actually looked at the data to see how that was affecting outcomes for different patient cohorts and populations. So what we did is we built a tool, and actually this is a tool we built in-house and wrote some algorithms in the back end of it. And now it's a self-service tool where you can actually go and look at your own performance as a physician and ask any question, right? You can say, pull 5 to 8-year-olds that have been put to sleep with this cocktail of opioid, and what were the outcomes? And so what the clinicians have done over the years is use that data to change the cocktail away from opioids, whilst watching the outcomes and finding that they have been able to change that and the outcomes are still the same, which means they didn't need an opioid-based medication because of the addiction layer. which is a problem in kids. So it's not rocket science. It's very much you understand how you practice and us giving people tools to be able to do that in the privacy of their office or homes without anybody critiquing you. Because that's the other problem you tend to have. You don't want to publish a list at top of the pops. What you want to do is say, you make changes, and if you can make changes, you can see whether those changes are effective. And over a period of time, it becomes a study. The physicians involved and they have published on this, where they started, what they learned, what changes they made. We're 100% opioid free outpatient surgery, 50% inpatient, and we're tending not to prescribe opioids on discharge. That's a win in the sense that we built a tool, but the work was still done by the clinicians. You still have to take the first step, right? In the 12-step program and say you have a problem. And then you have to look at your own data and how you practice. And I think most physicians on the day-to-day are so busy that they don't think about that. I go to my primary care, I'm chronically ill. He probably prescribes so many different medications in a day. When does he have time to look back and say, what happened last month? How many times did I give this particular medication?
He doesn't
And
have that
then I
time.
know that you can change, right?
Yeah. So last time we were on stage together a few years ago, we were talking about digital front doors, and it was all the buzz. And my question for you is, have these doors been fully built, or do we still have work to do on building these digital front doors?
So I think the digital front door is just, it's more of an evolution than a revolution, right? You build something basic. Many people just start with their EMR front end, something like a My Chart if you're an Epic shop. And then they add features on those. And we've done the same thing. We keep adding features to our front door, which does have My Chart integrated into it. And what tends to happen is our approach is to consult the customer and say, what should we build? What feature do you need? They said they needed wayfinding, so we built wayfinding into that. They said they wanted to know when their kid was out of surgery, so we built that into that. And so there's all kinds of things that you can build in. That's why I think it's an evolution, because there's always going to be something else the customer needs, and then you build for that.
Yeah, I read that you build this feature where patients are alerted once their discharge meds are ready as they're leaving the hospital. And it's something simple, but so impactful for parents, but also for workflow and discharge planning and all that stuff.
Yeah, and it stops the bottlenecks. I mean, where we started was observing what was happening in pharmacy. And they used to have the piece of paper that you'd pull from the machine with a number.
Yeah, like
The
a
number would
deli
show up
shop
on
or a
the screen,
butcher.
like a butcher shop. And the number would show up on the screen. Hey, your order is ready, type of thing. So when we had this complaint come to us in the group from the parents, we actually hadn't gone and looked. But then when we went and looked, we're like, oh God, this is not the way to do this. So you don't necessarily need huge amounts of technology. What you need to be thinking about is, if somebody brings something to you, go and observe it. Good thing about being in the technology space for all of us is we are very logical thinkers in how we solve problems. But we don't know what the problem is till we go and observe it ourselves. I like to say, let's go eyeball that. And once you eyeball that, it wasn't that hard for the team to say, if we're going to assign someone a number, we could do that electronically and show up on an app. Oh, your order is ready. It's just taking that paper and translating into something that looks cooler than it really is.
You built a Minecraft virtual hospital, I remember, to help kids just acquaint themselves with the hospital setting. Tell us about that project.
We're about 6 months post-launch of Minecraft. We launched it officially in Twitch TV. So I learn a lot because I'm old, and I learn a lot from kids, because I had no clue what Twitch TV was till we did a big launch of this product. And yeah, so we have our own Minecraft server. We have permission from Microsoft to do that because we wanted to protect the kids from bad actors, and there are bad actors in Minecraft. And yes, one of our surgeons and his child built out brick by brick the hospital in Minecraft on their own time. And now you can literally build things in our hospital in the Minecraft world, take things down, attack people, build forts, whatever you want to do, you can do that. I've also played it and I got killed immediately, so I'm not very good at these things. And now we're building more and more things into it as kids ask us to. So the latest thing because every year we have a game-a-thon. So this year's game-a-thon, the kids were asking for us to build the therapy dog. There's a great therapy dog, but he's so busy, people want to see him. So they're like, let's just build the dog into the Minecraft. And that's what we're building next. So once again, it goes back to what do people want? You keep adding value to the product set. And yes, it's used at every bedside, that people use iPad to access it. And you get a profile. When you leave, your profile is deleted. People that can come in and play, I can play in that environment, but I'm a trusted resource. They know who I am. We don't invite outside from the World Wide Web because there are predators who act like kids. So we've checked all those boxes and worked through the process. So there was not a process to work through. It's very successful. The problem with it is now, at the last session with the kids, they want me to build even more games, not just Minecraft, because they're like, you only did one piece of the puzzle, Zafar. You need to make the puzzle bigger. And I'm happy to do that, but I'm having discussions with gaming companies. And what I'm finding is that many games are not appropriate for kids. So I have to be very careful. Everybody say, hey, build Halo. The problem is Halo for Seattle children is probably not a good thing to build, right? Because it's got different connotations, it's violent, it's all of those things.
I would advise you not to build that one.
No, but I'm saying it's when you talk to people, and I'm not really a gamer, so I have to go find out what are the cool games. And most of the cool games are just not suitable.
That is a good point. I mean, and the other challenge is you've got a wide age range, right? You've got a lot of kids under 7. You've got some teenagers.
But Minecraft tends to traverse ages, and it seems to still have a huge following. Everybody knows about it, young or old. And so it's been successful for us to engage our patients when in the past we were trying to engage them with cable TV, which is horrible.
With Minecraft, you're able to give them control and power, which in the pediatric setting is the first thing you lose because you're now not in control of everything that happens. And for a kid, I think that's really empowering. My last question is about optimism. Zafar, what makes you optimistic about the future?
I think working in a pediatric organization is probably the easiest job I've had, and I've done it a few times in pediatric organizations, because every day you wake up, you don't have to think about why you do the job. Our job is to protect kids, get them healthy, take care of the holistic child. So I think the optimism for me is no matter what happens in the world, we have to look to our kids for the future. And if we take care of our kids, we educate our kids, we give them good values, they will lead the world forwards, probably in a better way than I could. And that's my hope for the future.
Thank you, Zafar. I appreciate your time and, of course, all the amazing work you do.
Thank you.
And now a thank you to our generous sponsors.
All right, we want to thank our sponsors for A Dose of Optimism. Our first sponsor is Nabla. Nabla. This will help keep us practicing longer. For 85,000 clinicians and counting, Nabla is the key to better balance. With real-time notes and dictation in one platform, clinicians are saving hours on documentation time and strengthening patient satisfaction. Learn more on nabla.com. And to Mercury Bank, online business banking for startups and small businesses. Go to Mercury Bank for powerful banking, simplified finances. And finally, we want to thank our presenting sponsor, KidsX. KidsX is a global ecosystem of pediatric innovators anchored by a consortium of the leading children's hospitals motivated to accelerate health innovation and transform care in pediatrics. Next, we go across the country to Children's Hospital of Philadelphia to talk to Dr. Bimal Desai. Dr. Bimal Desai is Vice President and Chief Health Informatics Officer at Children's Hospital of Philadelphia, where he oversees clinical informatics and digital health programs. He's a board-certified pediatrician and clinical informatician with a master's in biomedical informatics. He has over 15 years of experience developing innovative medical software and digital health solutions. Dr. Desai co-leads CHOP's digital transformation strategy, focusing on telehealth, remote patient management, and healthcare analytics, and he is recognized for his contributions to advancing pediatric care through technology. Enjoy my conversation with Dr. Bimal Desai. So, in our world, we regularly talk about adult and pediatric care being different, right?
children are not just tiny adults is something we regularly say. What does it mean to you, especially in your role as a leader of digital transformation at a big academic medical center? What's the difference between adult and pediatric care today as you think about healthcare delivery?
The obvious difference is that there's more participants. And so everything we do for these children is, of course, funneled through their parents, and it's got to work for both. It can't just work for one or the other. If we're asking a child to be available at 2 o'clock in the afternoon for a visit, then we're also asking the parents to take time off of work. That can add up for children who have a lot of medical needs. I think the other things that are different is especially when you look at the populations of children that we serve at places like CHOP and so many other amazing children's hospitals, is kids are generally healthy. And there's a very small proportion of children, I think it's like 2 or 3%, who are responsible for the vast majority of healthcare utilization within pediatrics. And it's obviously through no fault of their own, but it's because of the complexity of their medical illness. And so when you look at a place like CHOP, we are equal parts a community hospital for the region we serve here in Philadelphia, but we're also a hyper-specialized hospital. And the difference that I've seen is that when you look at a tool like remote patient monitoring, in the adult space, my impression from speaking with leaders at other health systems is that they're looking at common disease processes like hypertension, congestive heart failure. There's a whole host of conditions that they have found utility for remote patient monitoring. I remember during the pandemic, they're sending home patients with pulse oximeters and remotely monitoring their respiratory status. So common illnesses with solutions that relied on an inexpensive, largely off-the-shelf layer of commercial-grade blood pressure cuffs and pulse oximeters and things like that. And in pediatrics, I haven't yet seen the same. I would love to think that we have abundant evidence that remote patient monitoring would work for things like asthma, which is probably like our most common chronic illness. But where we are seeing signal is for children with rare and complicated illnesses like single ventricle heart disease and epilepsy. There's a whole host of less common pediatric conditions where we're finding utility for these tools. And I think that's been very exciting to explore, that we may end up having more use cases with smaller populations. And that also brings up some operational challenges about how to scale that.
So in the last, I would say, decade, it's been really interesting to see you and your hospital really focus on these smaller populations, smaller in terms of volume, because I think that the natural reaction is to mimic the adult model and look for populations that may be larger in volume within our hospitals. And I think a lot of hospitals have struggled to really see traction or value sizably come out of those populations. But I've noticed that you, through some of your programs, have truly identified the need amongst populations that may be small, but mighty in terms of the value. So walk us through some of what you found in terms of those use cases early on.
So they are the use cases specifically for remote patient monitoring. And to be clear, we actually call our program remote patient management because we don't strictly meet the CPT definition of what constitutes as a remote patient monitoring intervention. We found a couple of themes.
Just to clarify, you're not talking about continuous monitoring. You're talking about perhaps a daily check-in or some sort of cadence that may not meet the kind of continuous rigor that traditional RPM meets.
That's right. Traditional RPM, according to CMS, requires a certain number of observations per month using connected devices. And our devices are not connected. And we may or may not have that many direct vital sign observations per month. What we offer is just enough, right-size the intervention to the clinical population, but we offer just enough of that technology connection to families that our teams can get the data they need to then respond to changes in patient status. So we have a theme around medically complex discharges. And this is one that I think that we could grow to larger populations, including in the population that I see within general pediatrics. But it started with our infant single ventricle home monitoring program in cardiology. These are historically babies who have conditions like hypoplastic left heart syndrome. We know that they're at the highest risk for morbidity and mortality in what's called the interstage period between typically their first and their second surgery, a staged surgical correction. And we send them home with medical grade pulse oximeter, medical grade digital scale. We send them home these days with a smart stethoscope so that we can remotely auscultate their stent murmur. And none of those devices are connected back to our electronic health record with the exception of the stethoscope. And what we found is that this daily check-in for this population, and I think this has been the national experience also, has dramatically reduced the interstage mortality rate for single ventricle heart disease. Moreover, when we added these digital stethoscopes, we've actually now intercepted 6 to 8 cases of critical stent stenosis which in an alternate history, if we didn't have these tools, could have resulted in prolonged CICU stays or emergent readmissions or catastrophic presentation or even death at home. We've been very fortunate to find such great outcomes in that program. And then in the same vein, we've also seen success with our neonatology catch program. And this was the brainchild of Dr. John Chu, one of our neonatologists here. He had this observation that when we sent home medically complex former preemie infants from our NICU who go home with, an NG tube and supplemental oxygen and a complex medication regimen, that things would predictably fall apart at home. Not through any fault of the parents, not through any fault of the providers for not preparing them, but it's complicated to go from an ICU setting where you've got one-on-one nursing to a home setting where suddenly you are the care provider for that patient and all their complex medical needs. And so this intervention is similar to the infant single ventricle program where we check in daily. We're measuring the baby's weight through a digital scale. We can intercept if the baby's not growing correctly. We can add telehealth as needed. And it's a 30-day bundle that we literally prescribe to these patients when they go home. And that intervention for NICU catch has now been demonstrated to reduce readmissions by 45% for that population, which is amazing. And now we're actually doing some of the financial modeling to say, what does that mean in terms of financial feasibility for the program? And does this free up beds in our NICU, for example, to allow other children from our affiliate hospitals to be seen more expeditiously? And there's some interesting crossover between those programs where we have, of course, children with congenital heart disease who are in our NICU. So we're expanding this to a blended cohort of children who have both neonatology needs and cardiac needs. That's one group, sort of complex medical discharges. The second group we've been calling sort of the specialty care. So children with chronic medical illnesses who may need long-term surveillance. So for example, children who are receiving a ketogenic diet, which is a therapy for some types of epilepsy. Children with autism, where we can help families navigate how to identify and enroll for the correct services. Children who have febrile neutropenia, and we can monitor their fever at home when their white blood cell count goes down. Children who've had a concussion and are having some neurocognitive impact following that head injury. So those kind of chronic medical illnesses, they're a little bit different than the first ones I described, which are really prescribed at medical discharge from the hospital. The third use case that we found is perioperative and postoperative care, which I actually think is going to be an area of significant growth for us. We have 2 use cases in urology. We have a very large program in ear, nose, throat, the otorhinolaryngology team, where now postoperatively after your tonsilloidectomy and adenoidectomy and ear tube placement, we enroll you in a digital bundle to help monitor your pain, dehydration, oral intake after you go home. And that's 5,000 to 7,000 patients per year in that bundle.
How does it work operationally, right? Are these messages going out through text message portal? Are there staff that are dedicated towards monitoring and responding? It seems like a complex model to scale.
Yeah, that's a great point. So some of these cohorts are as small as like 70 patients a year, right? For example, the single ventricle cohort. The advantage that the cardiology group has had is that they've had a long-standing single ventricle home monitoring program that's fully staffed with a nurse practitioner, a dietitian, an attending physician of the day, and so on. And they were already committing this time to these patients in the paper world, having them write down their vitals in a paper journal. That division had a built-in workforce to do the digital version of this. NICU, we've had to negotiate with the division, okay, who's paying for the physician's time, the nurse practitioner's time, and we've come up with a model that works, and there are about 300 patients per year. Surgery also has found it valuable in the sense that this is replacing time that their nurses were already doing by doing phone follow-up for patients. So in the best case scenarios, there's a 1-for-1 trade-off that you're replacing burdensome manual workflows with more streamlined and efficient workflows, and it allows you to see more patients or to take care of more patients through the digital version of the same service. And I do think that's the difference in between peds and the adult space. I think our adult partners have been more successful at centralizing RPM, right? So they have a central hub and they have multiple use cases and a common pool of nursing staff to oversee them. We are very intrigued by that model. I think if we hit a tipping point of the right number of similar use cases, we would probably pursue the same. As it stands, what we're seeing that's similar to that is within cardiology, there's 4 or 5 use cases, and they may develop their own little RPM neighborhood, right? Where they allocate staff to do all the surveillance for all 5 of their populations. And we're open to all the models, whether it's centralized, whether it's federated, whether it's this idea of RPM neighborhoods. But we followed the lead of our clinical partners to say what works best for you now and where should we go in the future.
What's the reaction been with providers and payers as you're doing some of this work? The data sounds appealing. What do the payers think? What do the providers think?
Right. So for remote patient management specifically, the payers in our region, I think, are still eager to see more data. And the good news is that the more use cases we have, the more data we've been able to generate. So things like the 45% reduction in readmission for neonatology babies or graduates, the number of intercepted critical complications in the single ventricle home monitoring program, things like that are really compelling and persuasive. And so our hope is that if we will have enough data to show them to say, look, we're very selective about which clinical programs we list in remote patient management. If you trust us and you trust our rigor and you trust the outcomes that we've been able to demonstrate, we think this is something you should consider reimbursing us for. It is pretty resource intensive to do these interventions. And in the best case scenario, we found that it actually creates internal efficiencies that help us pay for the program. For example, we have a whole category of kind of operational use cases, like our specialty pharmacy. This is replacing the very manual process of confirming that patients' meds and supplies were delivered on time and that their refills are due. And all of that sort of manual management we can now do electronically. And it's been very helpful for that population.
You're an advocate of the NPS model and Net Promoter Score as you think about patients and providers. If you were to guess, what do you think patients and providers are thinking about these new digitally enabled care models at your organization?
We do have those data, and the data are generally very favorable, especially for some of the more medically complex cohorts, like the single ventricle group. Families, I think, do really appreciate the service. I'm a hospitalist general pediatrician, so I take care of inpatients and will sometimes discharge these medically complex children who graduated from our ICU or NICU to go home. I'm catching them on the tail end of their hospitalization. I remember talking to the mother of twins who had been in the hospital for months. And one of the twins was healthy and had gone home. The second twin was going home with a lot of medical complications, was going home with an NG tube and supplemental oxygen and 4 or 5 different medications and some cardiac meds and things like that. And I remember asking the mother, like, what she was worried about when she went home. She's like, I'm worried about losing all this. I'm worried about not having the system of support that we have here at CHOP, and your NICU is right downstairs. And so if my baby gets sick, we can just wheel them down and bring him back later. And I mentioned to her that my team was looking at this NICU Catch program where we would have a 30-day bundle to follow families after they went home, and we could offer them telemedicine and daily check-ins and educational videos about, oh, here's the reminder for how to flush the G tube, or here's how you mix the formula, or here's how you program the pump, or whatever the medical device was. And I asked her, is this something you'd be interested in? I just felt like she visibly relaxed, and she was like, we would absolutely love this. You could just see the sense of relief knowing that we were going to be able to support her for another 30 days after she and her husband took their second twin home. It was really heartfelt. Her husband was finishing his medical leave for the pregnancy, so he had to go back to work. Mom was worried about how she was going to take care of both twins with their medical complexity. We forget how complicated it is and how difficult it is for the families and parents of medically complex children, to the extent that these RPM bundles fill a gap, a real gap for these families. I think it's absolutely worth doing.
Your story reminds me of some patient interviews we did a few years ago. The way it was described to me was, it feels like a cliff. You've had this amazing care, people looking after you and your child for 24 hours at some of the best hospitals in the country. And then you go home, and for many families, it feels like a cliff. It feels like they've gone from all the resources they need to perhaps feeling so alone that they've got nothing, or they've got very little when they need something. It's a huge emotional toll for a lot of families. So I imagine the story you shared, providing a bundle of remote management services digitally enabled, I could see how it feels like they've now got the support, at least for that 30 days. It's like a step down from that inpatient care. So as you look to the future of this digitally enabled care model, what's your hope and prediction, let's say 3 to 5 years?
My hope and prediction is that we exhaustively look at the opportunities for this sort of blended model of hybrid care, right, where it's a little bit inpatient, a little bit outpatient, a little bit something in between, where we are doing some digital hovering. And we're seeing, especially with the success in these smaller cohorts, the medically complex, chronically ill population, we're seeing interest from other divisions too, right? Like even my own division, general pediatrics, where we take care of a lot of medically complex children. We have an entire inpatient complex care service. We have a program called Compass Care that's specifically for children with high medical complexity who are followed by more than a handful of specialists for their chronic medical conditions. I would love to figure out how do we extend RPM to those groups. The challenge is that a lot of the divisions who are our early adopters did so because they had the built-in staff to support this, right? They had the resources, they had the personnel who could do the population health style monitoring that these programs require. And if I'm thinking about my own division, general pediatrics, we don't have an ambulatory arm within our division. We have one academic practice that's called the faculty practice, but I think it would be unfair to make them do RPM on behalf of the entire hospitalist service. And so now we're getting to the more adult-sized questions, right? What would it take for us to centralize RPM? How many nurses would we have to hire? Who would pay for it? Where would they sit? What kind of technology layer do they need? Like, we're asking the practical questions about how to build and scale RPM now.
Dr. Desai, thank you so much for joining. Always a pleasure, and amazing work that you're trailblazing through your work in digital transformation over at CHOP. Thank you.
All right, thank you for joining us for your dose of optimism. Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and thank your crossing guard. And if you're so inspired, donate to your local children's hospital. All right, see you next time. The content, views, opinions, and information presented on this podcast do not reflect the views of Children's Hospital Los Angeles or of the sponsors of the podcast. CHLA does not endorse the views, opinions, and information presented on this podcast, and CHLA specifically disclaims any legal liability or responsibility for the podcast content.